So today I'm going to be presenting about some work that I did down in Florida for my practicum. I was at the Florida Prevention Research Center working with Dr. Mahmouda Pasha and a coalition that was working to address severe maternal morbidity, also known as SMM. That'll be the short form that I'll use during the presentation, in Hillsborough County. So Hillsborough is the region surrounding Tampa Bay. Before I jump into the presentation, I just want to acknowledge that I'm presenting today from the unceded territory of the Anishinaabe Algonquin Nation, and that much of this work was also conducted on the unceded territory of the Seminole people in Florida and on lands used by other historical groups, including the Calusa and the Tocobaga peoples. So why did I go all the way down to Florida for my practicum? It was actually a paper that was one of the required readings in Dr. Little's Population Health and Health Promotion course that really inspired me. It's this paper on the screen in front of you, and it describes something called community-based prevention marketing, which is a framework that was developed at the University of South Florida 20 years ago. And basically it combines participatory research with community engagement, behavior change theories, and something called social marketing, which I had never heard of before. So social marketing basically applies commercial marketing principles to promote positive social change. And what I found so intriguing about it was the fact that social marketing and CBPM specifically have been used for health promotion to promote change at an individual level, but also for advocacy and systemic change. And obviously now it's being used with a pressing maternal health issue in the US. So this slide just provides an overview of CBPM, the community-based prevention marketing framework. I won't go into too much detail about it, apart from mentioning that the coalition that we were working with, they moved through steps 2 and 3 during my practicum. So step 2 basically involved them reviewing a long list of evidence-based interventions that could potentially be used to address SMM, and then reaching consensus, whittling that down to a list of 5 interventions that they thought could be the most effective. At that point, the USF team, myself included, conducted literature reviews on those 5 or so EBIs, compiled the evidence, took it back to the coalition, they reviewed it, and then they voted on which intervention they wanted to move ahead with. So the Hillsborough County SMM Task Force was the multi-sectoral task force that we were working with on this issue. So it included representatives from governments, not-for-profits, community-based organizations, people with lived experience of SMM. And this task force really grew out of some health equity analysis work that was done in Hillsborough that identified SMM as a pressing public health concern. So what is SMM? What is severe maternal morbidity? So it's defined as a range of serious pregnancy and delivery complications that result in short and long-term consequences for a pregnant person's health. So the US Centers for Disease Control has identified 21 SMM indicators. They range from things like blood transfusions, so indicating that a pregnant or postpartum individual might be hemorrhaging, for example, to respiratory distress, convulsions, heart failure, blood infections, hysterectomy, etc. So I was actually surprised to learn that severe maternal morbidity was such a pressing public health problem, but in fact, in the US, they have some of the worst maternal outcomes among high-income countries in the world. So the SMM rate in the US has increased by almost 200% in the last several decades, and now it affects about 60 million people in the country, 60,000 people in the country each year. So what are the contributing factors to that increase? There's a range of potential factors. So rising maternal age at pregnancy, underlying health conditions, obesity, the cesarean rate for deliveries. These are all potential contributing factors. But the social determinants of health remain key predictors of SMM. So racialized individuals, those who have low levels of education, those with no insurance or who rely on Medicaid specifically. So that's the publicly funded insurance for low SES individuals in the US. And incidentally, Medicaid funds, I believe it's 50% of all births in the US each year. So those folks are at significantly increased risk of SMM. In Hillsborough County specifically, the SMM rate among Black women, just as one example, is almost 2 times that of white women in the county. So pregnancy medical homes, or PMHs, as I will call them, were one of the interventions that the SMM task force was considering, and I was actually tasked with doing the lit review, the scoping review for this particular intervention. So PMHs are essentially a spin on something called the patient-centered medical home, which I actually never heard of before. So this is an approach to primary healthcare that was really promoted following the adoption of the Affordable Care Act, Obamacare, in 2010. And as the name suggests, it's patient-centered. So it's an approach to healthcare. It's not a bricks and mortar physical space. So we'll just clarify that right out of the gate. But essentially, folks that use or teams that use this approach are more concerned about a patient's questions, their health concerns, their health goals, rather than simply focusing on a diagnosis, for example. They engage in team-based care. They look at social determinants of health and find linkages to community resources that might assist patients with that, whether that's for food security, housing, et cetera. They engage in care management and coordination. They also engage in performance measurement and improvement. And there's a little logo in the top right-hand corner of the slide there, which is quite important. And that's this organization called the National Committee for Quality Assurance. So they actually accredit patient-centered medical homes in the US, provided they meet all of the criteria on the screen in front of you. And this model has actually been associated with improved patient outcomes, cost savings, care quality, and also the mitigation of health disparities as well. So as I mentioned, PMHs are essentially patient-centered medical homes applied to perinatal care, however, with one key difference. There's currently no accreditation of PMHs in the US, and as a result, there's really considerable diversity in terms of what they offer. So the research question that I used for my lit review was the following: what is the impact of PMHs compared to standard care on SMM rates among pregnant and postpartum individuals in the US? I searched 3 different databases: PubMed, CINAHL, and Web of Science. And I also looked for gray literature. I looked at the Cochrane database and did a number of website searches as well. After I applied my inclusion and exclusion criteria, which were, they were numerous, but basically I was looking for studies that were conducted in the US in the last 7 years and that were published in English. And that left me with just 6 studies. So in terms of the findings, as I mentioned, there were very few studies that looked at PMHs as an intervention for SMM specifically. In terms of the studies that I did find, excuse me, there was a wide range in terms of the interventions that were actually applied, and in terms of the study designs, the quality of the studies and the findings themselves. So there were several recent studies that found PMHs to be associated with SMM, reduced SMM, and maternal hospitalization. However, the largest evaluation to date that looked at more than 9,000 PMH participants over a 5-year period found that other models were actually more effective at preventing SMM. So a key challenge of PMHs is that they're ill-defined and inconsistently implemented. So this made it really difficult to make an apples-to-apples comparison between those studies for this lit review. In terms of recommendations and next steps, national standards would be really helpful. This would help to ensure that PMHs are all applying evidence-based best practices and that they're doing so at sufficient intensity to actually have a positive impact. We also need more research on PMHs, specifically their effect on SMM. And my understanding is that there's actually several studies that are in the pipeline right now, so that's definitely positive. And we also need studies that consider race and ethnicity specifically. There was some new federal funding that was announced last year out of the White House as part of its blueprint for addressing the maternal health crisis. There was $25 million earmarked specifically for PMH interventions pilot projects. So that could help to address some of the knowledge gaps. And for its part, the SMM task force voted to implement a PMH intervention in Hillsborough County, and they've also applied for some research funding to hopefully contribute to the PMH knowledge base. So that's something that I'll be interested to see the results of in the coming months. So that concludes my presentation, and I'd certainly be happy to answer any questions.